All right, so welcome back. We are coding week 8, chapter 9 and 10. How was homework, ladies?
Good.
Did you feel like you're starting to get the gist of it?
Yes.
Okay. And you were on Evolve, so you saw your exams?
There was only chapter 1 exam on there.
No, I
Okay.
did.
That's all right. So you should see chapter 1, chapter 2, and chapter 8. And what I did for chapter 2, I know I said there wouldn't be an exam, but what I did for chapter 2 was I created a true false. So I'd like you to take chapter 2 exam afterwards. Okay? And you
Okay.
should see chapter 1, chapter 2, and chapter 8.
When did you put them on there?
Chapter 1 I put on over the weekend, and chapter 2 and 8 I think I put on like Monday night or Tuesday. So
Okay.
when you get a chance, I understand that we didn't have access to that course. The rep was really good last week, and getting it to me, quickly. Usually it takes almost a week to get those things. So I was able to get you ladies set up to have access to it, and I will finish creating the rest of the exams this weekend. So you at least have chapter 1, 2, and 8 right now.
Okay.
So the ideal thing is to try and do the exams after every class so that the information is fresh in your mind. I'm
I
not
did
gonna
it
know.
yesterday,
Okay.
and 2 and 8 still weren't on there. I don't know.
Okay, that's fine. Yeah, yesterday, Tuesday. I probably did them last night.
Oh,
I
okay.
think I did them last night.
Okay.
So don't worry about it. Okay. I won't hold it against you. So, want to do answers first for chapter 1, chapter 2, and chapter 8?
Yep.
Okay.
In the workbook or the book book?
We're going to do it in the buck book first. So chapter 1, practical and review. All right. So number 1 in the buck book, chapter 1, we're on page what, 24?
Yes.
Okay, number 1, you should have A and B. Do you have that, Anita? All right, and then number 2, you should have CMS. Number 3, Social Security Administration. Number 4, 65 and over, some disabilities, and permanent kidney failure requiring dialysis or transplant. Number 5, work, overhead, or practice expense and malpractice. Number 6, resource-based relative value scale. Number 7, elderly. And 8 would be Max or Medicare administrative contractors. All right, so far so good?
Yep.
All right, let's move on to, if you want to shut the door behind you, please. Thank you very much. All right, chapter 2, review and practical, page 45.
Did we do practical for 1?
I think so. It was 9 through 13, right?
Yeah.
So C, D, I, G, and J. So practical for chapter 1, page 24. 9 is C, 10 is D, 11 is I, 12 is G, 13 is J. All right. Now, chapter 2. Page 45. And number 1, true.
The 47
Two.
for us.
Oh, sorry.
That's okay.
I still don't have my book. I have the old one. I got the course, but not the book. Okay, number 2 is true. 3 is false. 4 is false. 5 is D. 6 is B. Now 7, what do you have for that one, Kelsey?
D.
Which is October 1st, 2000
15.
Yes, perfect. And number 8, what do you have for that, Anita?
Yeah.
Which one?
Yeah. Yeah. Oh no.
C,
Yeah.
activity?
Oh, C activity. Yeah.
Yep. Number 9. Number 9 is gems, B. And 10 is D, combination. Let's go over to the practical. 11 is D. 12 is B. 13 is C and F. 14 is E. 15 is A. 16 E. 17 A. 18 C. 19 D. And 20 B. All right, how did you both do with those?
Good.
I did that.
Okay. Anita, if you ever need to set up some phone time, or just let me know, okay?
Yeah, sure.
All right. And then it was chapter 8, right?
Yep.
All right, so let's turn to page 243. So the first one is C. Number 1 is C. Number 2 is E. Number 4, A. Number 5, D as in David. All right, what do you have for 6, Kelsey?
C.
3 was B. I circled D, but I know it's either C or D.
6 is C.
Okay.
6 is C. Good call, though. All right. What do you have for number 7? Anita, did you do 7?
No, I didn't do
Okay.
that. I can
Okay.
read. If the following is not stated.
Yep. Do it.
Facility.
It is D. You're correct. Excellent.
No. Yeah.
Good job. All right. 8, Kelsey.
C.
C is correct. 9 is B, and 10 is what, Anita?
Volume 3 is tabular.
Yes.
No, sorry. Volume 3.
A, yes. Tabular
Yeah,
list,
yeah.
A. All right. 11 is B. 12 is D. 13 is E. 14 is A. And 15 is C. So let's do the practical. And you were supposed to use your ICD-9 book for this, which when you did that, it gave you a little practice looking up the codes. So 16, you should have malignant melanoma of skin of breast, 172.5, and malignant neoplasm of skin of breast, 173.50-17359. 17, you should have includes infarction, and in parentheses, embolic and thrombotic, and occlusion. And if these are answers that you would like me to send you copies of if you didn't get a chance to finish them, just send me an email and I'll be happy to do that, because sometimes I can speak too fast. Number 18, under category 805, which codes use the subclassification 0 through 8? It would be 805.0 through 805.1. Number 19. No, the code is italicized with instructional note to code first the underlying disease. Number 20. Diseases of the respiratory system, 460-519. 21. Acute respiratory infections. 22. Acute sinusitis, 461. 23. Acute sinusitis maxillary, 461.0. 24. Acute laryngitis without mention of obstruction, 464.00. 25. What do you have for that one, Kelsey?
Use additional code to identify infectious organism.
Yes. And 26. Pneumonia and influenza, 480.0-488.19 are excluded. 27. All right, so in these, we're supposed to underline the main terms. What do you think is the main term in 27, Anita?
Main term is not a chronic.
No, it is pancreatitis. So this is what I want you to think about when you're looking at words.
Main term is like, pancreas. I was thinking pancreas. Yeah, pancreatitis.
Yes.
It's not an anatomy, right? Yeah, anatomy.
Yes. And you know what? We all make that mistake when we first start doing these main terms. We think chronic but what we have to think about is, what is the person coming in for? It's not that it's chronic that the patient's there, it's that he is suffering from pancreatitis. And we all know from our terminology that itis means what?
Pain.
Pain.
Pain,
Itis,
inflammation,
pain.
itis, pain, inflammation. All right, number 28, Kelsey.
Cholecystitis.
28,
28.
Oh,
Which one?
abscess. Sorry.
yes, abscess. Mm. All right, 29 is cholecystitis. 30, Anitha.
Pain. No.
Yes, yes. So if you can remember nothing else
Yeah,
when
it's
we're
fine.
doing this, what is the main term is the reason that they are coming in. So it's pain. Perfect. 31, Kelsey.
Mastitis.
Yes. All right. Using your ICD-9 Volume 2 alphabetic index, what I want to know, is this an essential or non-essential modifier? So 32, is it non-essential or essential, Kelsey?
Non-essential.
Yes. 33, Anitha.
It's like essential means it's in
Yes,
so
essential.
with the
Perfect.
bracket.
Yep. 34, Kelsey.
Essential.
Yes. 35.
Non-essential.
Non-essential.
Yes. 36 is non-essential.
Non.
37, what do you have for that, Kelsey?
Exanthum subitum.
Yes. 38 is what, Anitha?
I don't have. I can look.
Okay.
Main term emotional index. The other term emotional concept. Okay. Yeah, here emotional. The term for emotional. It's crisis.
Yes. All right. And what do you have for 39, Kelsey?
No, it's 204.1.
Because,
I didn't write because.
okay. Per excludes no, and remember to assign the 5th digit 0. All right. Number 40 would be no. 753.29 per the excludes note. And then 41, you should have 331.0, 294.11, and then 42, 022.1, and 484.5. Excellent. All right, let's go into the workbook. We'll start with chapter 1. All right. So, number 1 in the workbook, chapter 1, you should have person eligible for disability and person with kidney failure or transplant. Either order, it doesn't matter. Number 2 is CMS. 3 is Social Security admin. 4, deductibles, premiums, and coinsurance. 5, 80%. 6, relative value unit. 7, 12. What do you have for 8, Kelsey?
November and December.
Yes. What about 9, Anitha?
Under what act? Oh, I don't remember.
Okay, it's OBRA, O-B-R-A.
Oh, okay.
Okay? All right, 10 is no.
No, yeah.
11 is beneficiaries. And 12 is Max or Medicare administrative contractors. 13, Medicare Advantage. 14, Health Insurance Portability and Accountability Act, also known as HIPAA. And 15, Administrative Simplification. 16, Electronic Data. 17, National Provider. 18 is what, Kelsey?
I don't have that one.
All right, 18 is unit. All right, 19 is limiting.
Limiting.
20,
Is it 125?
20 is 125. 21 is internet only. 22 is gatekeeper. 23 is staff. 24, individual practice. 25, program and all inclusive. How did you both do with those? How many out of 25?
I think I got 20 out of 25.
Good. Anita?
I didn't do those.
Okay, that's fine. That's fine. All right, let's move on to chapter 2. What do you have for number 1, Kelsey?
True.
Yes. All right, number 2, Anita.
Yes, true.
Yes. 3, Kelsey.
True.
Yes. 4, Anita.
I think NU nation.
It's
NU.
true.
It's true. Yeah.
It's true, yes. Number 5, Kelsey.
False.
Yes. False. 6 is false. 7 is true. 8 is false. 9 is true. And 10 is true. All right, 11. 11,
F.
you should have F, yes. Kelsey, why don't you give me 12 through 16?
12 is D, 13B, 14A, 15C, and 16E.
That is correct. 12 is D, 13 is B, 14 is A, 15 is C, 16 is E. All right, let's do 17. 17 should be D as in David. 18A, 19F, 20B, 21E, and 22C. All right, everyone do well on those?
Yes.
Did you find those weren't too bad to look up after all?
The what?
They weren't too bad to look up after all?
Oh, no, not at all.
Yeah. How about you, Anita? How did you feel they were?
I did for some time, not. I didn't work a lot. Maybe
But-
next week I'll do it. I'll go through everything.
And if they're not always going to be multiple choice, then, because when you pull it up, it doesn't put in the periods. I
Right.
just knew the answers. So I don't know if
Yep.
it's always going to be multiple choice. But I would hope so.
For the exams?
Well, just for like stuff in the workbook. That way we know where the period goes.
Right.
Yeah.
Right. No, they should have that information. I mean, it should have, yes. For your ICD-9 codes, your period is always going to be the 3 characters and then the period.
Yeah.
So the ICD-9 will always have 3 preceding the period. With your ICD-10, when we move into that,
Alphabet.
The letters, the numbers, and then a period?
right,
Yeah.
right.
Okay.
Yep. All right, let's do chapter 8. All right, chapter 8. Number 1, F. 2 is G. 3, A. 4, I. 5, H. 6, L. 7, J. What do you have for 8, Kelsey?
E.
E. Anitha, 9.
NEC, like. I don't know. What is
D.
NEC?
Not
D.
elsewhere class.
Yeah.
D.
Oh, yeah.
All right. 10 is K.
Yeah.
All right. And 11 is B. 12 is C. All right. Turn the page. All right. 13. A. 14 is B. What do you have for 15, Kelsey?
14. 15 F.
Yes. And want to try 16, Anitha?
Yeah. Modifiers is like essential modifiers and non-essential. Terms in, yeah, it's a B.
Very good. B it is. I know you know this stuff.
C.
All right. And then 17 is C. 18 is D. 19 is A. 20 is E. And 21 is G. All right. 22, Anitha.
Mm. Oh, yeah.
C.
Oh, no, sorry. It's volume 3. Oh, ICD 9, volume 3 is like hospitals. Yeah, clinics, sorry. Yeah, yeah.
Yes, C. 23, Kelsey.
D.
Yes, D. All right. Anitha, 24, is it true or false?
True.
The location of the includes and excludes notes has no bearing on the code selection. That would be false. Because if you see includes and excludes underneath the code selection, it does have an effect on it. Number 25, Kelsey.
True.
True is correct. 26 is false. 27 is true. And 28 is false. All right, 29, Anitha, what is the main term?
Main term is like a reaction.
Yes. And how about 30, Kelsey?
Fracture.
Yes. 31 is obstruction.
Obstruction.
32, Kelsey?
Herbs. No.
It's actually
Palsy.
palsy. Yes, palsy. All right. And 33, Anitha?
It's like a high risk pregnancy.
So what's the main term? What are they presenting with?
Yeah. High risk. Oh, okay. Maybe supervision.
It is pregnancy. They are
Pregnancy.
presenting
Yeah, just
because they are pregnant.
oh, okay.
Okay. And what is 34, Kelsey?
10.
Stenosis.
Yes. And 35 is respiration. And 36 is meningitis. All right. Now we need to identify whether they are category, subcategory, or subclassification. 37, you should have subcategory. 38, subclassification. 39, category. 40, subclassification. 41, subcategory. 42, subclassification. 43, diagnosis code. 44, diagnosis code. 45, procedure code. 46, procedure code. And 47, diagnosis code. All right, so the practical, using your ICD-9 Volume 1 tabular list, locate the first page of Chapter 10 and answer the following questions about the chapter. Anitha, what do you have for the number 48?
Okay. I don't know.
That's okay. Take your time.
Okay, disease of genitourinary system. That's the
Yes.
one.
10 is diseases of the genitourinary system. 49, Kelsey.
Nephritis, nephrotic syndrome, and nephrosis.
Yes. 50 would be 580, acute glomerulonephritis. Glomerulo, yes, I have trouble with that one. And 51 is 580.0, acute glomerulonephritis with lesion of proliferative glomerulonephritis. 52, 580.81, acute glomerulonephritis in diseases classified elsewhere. So Anitha, you would answer these questions here all based on that first page of chapter 10. Okay?
Yes.
All right. Number 53, we want to know, is it essential or non-essential? 53 is essential. 54 is non-essential. 55 is essential. 56 non-essential. And 57 essential. 58 is no, 022.3. 59, no, 770.0. 60, no, 289.2. And 61, 002.0 with 484.8, and you want to make sure it is in that order. Okay? How'd we do?
Good.
Not too bad?
Nope.
Excellent. All right.
Are
So
you
let's go
holding
ahead.
up, or did you already put up pictures of all your tabs on the buck book?
Oh,
Because I just want to make sure that they're perfect.
there's no such thing as perfection. Give me one moment. Let's see here. All right. Tabbing on Buck Book. All right. All right. Got it. Let's see. One moment. All right. I will send it to both of you after class. I have it right here.
Thank you.
Yep. All right. Okay. Syllabus. So we reviewed the answers for chapter 1, 8, and 2. And now we're going to go over chapter 9 and 10 in our textbook. So what I would like you to do is have your ICD-9 book open. And you're going to have it open in your guidelines to the outpatient section 4, which should be page 46. So what page in your textbook?
It's
249.
248.
Okay, so chapter 9 in your textbook. All right, so I'm going to take just a quick moment here, and I'm going to show you what I have highlighted and underlined. Can you see it?
Yeah.
All right. So as we read along, as I do my talk, it should coincide with the guidelines. And this is where you can be underlining and highlighting those things that might need to stick out for you, okay? So I'll try to go slow. And what I might be able to do also, I might even be able to take a picture. Let me see if that will work. Oh, actually that could work. Okay, let me do that. So what I'll do is we'll have the class. I'll indicate what things I think you need to highlight and underline, and I'll take a picture, and I'll be able to send it to you in email so that you can see what I did.
Perfect.
Why didn't I think of that earlier? Silly me. All right, hold on. Next picture. All right. Sometimes I scare myself. All right. So chapter 9 is all about your ICD-9 outpatient coding and the reporting guidelines. And if you look in your your ICD-9 book on page 46, you'll see that it starts off with Section 4, Diagnostic Coding and Reporting Guidelines for Outpatient Services. So you might want to make reference right there at the top that this refers to Chapter 9 in your book.
What number is ours? 46.
46.
So these follow the inpatient guidelines in certain situations where there are not any clear outpatient guidelines. So when we talk about outpatient services, we're talking about the physician's office. We're talking about, that lonely old guy who is all by himself in his practice, probably only has one staff member. That is your outpatient services. That can be your chiropractor, your ear, nose, and throat doctor, your OBGYN, your dentist, your eye doctor. These are considered outpatient services.
But your PCP would be inpatient?
No, your PCP is going to be outpatient as well because they are outside of the hospital.
Right.
When we talk about a physician's office, it is considered outpatient. So your outpatient guidelines might not always address the specific sequencing or diseases that your inpatient guidelines do. So you're just going to have to follow your guidelines. Follow your inpatient guidelines in certain situations where you don't have clear outpatient coding guidelines. So on a rare occasion, we may refer to inpatient guidelines if it's not clear to us in the outpatient guidelines. But it would be very rare. In the outpatient setting, when we use the term first listed diagnosis, that means that it is primary. And this is used instead of principal diagnosis. So when I am referring to first listed diagnosis or primary diagnosis, that is being used in place of principal diagnosis. So principal first or primary. That's what the terminology that we want to be remembering throughout here. And you'll see that that is mentioned right there on page 46 underneath the letter A, selection of first listed condition. In the outpatient setting, the term first listed diagnosis is used in lieu of principal diagnosis. And when we talk about first listed, we're talking about their primary symptoms. That's what that means. When we talk about outpatient surgery, down below, A1, outpatient surgery is the reason for the surgery. So you will code for the reason of the surgery. And remember that your primary diagnosis is synonymous with first listed diagnosis. You would either, you can have either term replace that term principal diagnosis. If the outpatient surgery is canceled, you're still going to code the reason for the surgery, because then you're going to also indicate when you're coding that it's been canceled. So it's not necessarily that you would be charging for it, it's that you would be coding it so the payer and the hospital knew that you were planning the surgery and it got canceled. Observation stay, down under number 2, observation stay. Observation stay is a medical condition that is what caused the admission. So the patient is admitted for observation for a medical condition. You would assign the code for the medical condition as the first listed diagnosis. So observation stay, assign a code for the medical condition. And it's all right there in that paragraph under number 2, observation stay. When the patient presents for outpatient surgery and develops complications requiring admission to observation, again, highlight code reason for surgery as the first reported diagnosis. All right. When we have complications from an outpatient surgery that leads to an observation, we want to make sure that we are reporting the reason for the surgery as the first diagnosis and then code the complications that are necessitating the observation. So these first 2 slides of information that I'm sharing with you are all in this first paragraph in the half, from letter A, selection of first listed condition, down to outpatient surgery, observation stay, right there. That's everything. You don't have to underline everything, just the key points. So in letter A, first listed and principal. That's what you should highlight or underline, just so they jump out at you. And what does first listed and principal mean? It is the primary symptoms. Okay, then under number 1, outpatient surgery, you want to highlight or underline outpatient surgery, code the reason for the surgery. And then number 2, observation stay. If they are admitted for observation for a medical condition, assign a code for the medical condition as the first listed diagnosis. All right, are you both following me? Is that okay? Does that
Yep.
all make sense?
Yeah.
Yes.
Okay, good. All right, so now we move on to selection of the first listed diagnosis. This is where we are coding the condition for the encounter. So why did the patient present? It might not necessarily be the most serious condition that is noted, but why did the patient present? That's what we want.
Like symptoms?
Yes, what's the primary symptoms? So a patient comes in with, chest pain and has a history of myocardial infarctions. But why are they there, right there in that moment? Because they're having chest pain. Okay? You would document the condition that is would then be responsible for the services that are provided. Then you would also list those coexisting conditions. So patient comes in with chest pain. All right, we document it. What are the services that we're going to provide with them? And then what are those coexisting conditions? So he has chest pain, but what else is going on? He has COPD. He is a smoker. He has had history of heart attacks. Also has diabetes. Okay? So sequence the primary diagnosis first. What's the reason for the encounter? Your diagnoses and your services must correlate. You must establish medical necessity. If there isn't any correlation, there won't be any reimbursement. All right. When we talk about codes that describe symptoms and signs, codes that describe symptoms and signs, letter E. They can be the first listed diagnosis if there is not a specific diagnosis available. Also, make sure your diagnoses, keep in mind that on that initial encounter, you might not always have the diagnoses established because they come in with all kinds of signs and symptoms, but we're not supposed to code just the signs and symptoms. We're supposed to code the definitive reason. So when we don't have a definitive reason right off, we will code some signs and symptoms, and then once we get all of our test results back, we will be able to give a definitive diagnosis. Does that make sense for both of you?
Yeah.
Okay. All right. Letter B, coding from 001.0 through V91.99. You want to be familiar with these because they are used in many areas. They are used for diagnoses, symptoms, conditions, problems, complaints, or any other reason for the visit. A lot of your clinics that are specialized may use some of these codes more than others, but you want to become familiar with all of these codes. So if you are specializing in cardiology, other than family practice, you may only use a small amount of these diagnosis codes. But you want to follow the guidelines so that you can properly code your diagnosis. All right, letter C, accurate reporting of the ICD-9 diagnosis codes. Your documentation should describe the patient's condition, and you want to use terminology that includes specific diagnoses, symptoms, problems, and reasons for the encounter. Letter D, selection of codes 001.0 through 999.9. Again, you want to make sure that you are using the most appropriate ICD-9 code from the correct chapters to describe the encounter. And you will just, choose them from the appropriate section. Guideline E, codes that describe symptoms and signs. We talked about this a little bit. Chapter 16 will contain many of your codes, but not all of them for symptoms. So chapter 16 is where you'll find a lot of codes for symptoms, but not all of them. You would refer to this chapter when there is no definitive diagnosis given. And then once you have the definitive diagnosis, you would then be able to change your diagnosis code. You would still reference in the index prior to confirming in the tabular section of your book. Guideline F, encounters for circumstances other than a disease or injury. Well, give me a moment, hold on. All right, what I want you to do is make a note here underneath Guideline F that says page 32. And what I want you to do is put your hand here so you don't lose your page. I want you to turn back to page 32 in your guidelines. And what you will see over on the right-hand column is chapter 18, page 32. On the right-hand column, you'll see chapter 18, classification of factors influencing health status and contact with health service, supplemental V01 through V91. So this is where you will find your guidelines for your V codes. Now, what I want you to write next to chapter 18, give me one moment. This is where extra things come in handy to mark your place in your book. I want you to, next to chapter 18, write page 1008 in the tabular. Page 1008 in tabular. All right, so next to chapter 18 on page 32, page 1008 in the tabular. Now what I would like you to do is turn to page 1008 in your tabular. And you'll see at the top of the left-hand column, 1008. At the top of the left-hand column, it gives you information about your V codes, supplementary classification of factors influencing health status and contact with health services. And you see what it gives you right there? It gives you some notes, and then in the green boxes, it gives you part of your guideline already. So the nice thing about this book is that you already have notes within your sections to help you when choosing your codes. So you don't have to always refer back to the guidelines, but if you need to read more of the guideline, you know what section you need to go to. So we're on page 1008, and you see they give you 2 green boxes that gives you some small information about guidelines. Section 1C 18B. So 1C 18B brings you right back to page 32 in your guidelines. Do you see that?
Yeah.
And if you notice on the side of the book where we have the colored edges,
Yeah. But they said it's 17, right? Section 1C 17.
Well, because 18 starts right there.
Yeah. Section. Details. Okay.
so just a few tips to kind of help your getting around the book, okay? Wherever you can make notes referring you from, section to section is going to be helpful, especially once you tab it, you'll be able to go to that section much quicker, okay?
I think it would save me about an hour with the homework if I had tabs on it.
Okay, I will definitely make sure I send those tonight. All right, let's go back to page 46. Now, for your V codes, as we just discussed, this is for someone who is in contact with health services, but they might not necessarily have a health problem, okay? So there are 4 primary circumstances for the use of V codes. So this is where we want to put something in between these 2 pages and go back to page 32. So right under on page 32, starting with 18A1, page 32, 18A1, it lists the 4 primary circumstances for use of V codes. So the first one is a person who is not sick, but they obtain health services such as a vaccination, a health screening or testing to act as an organ donor. 2, a person with a resolving disease or injury or chronic condition that might require continuous care, receiving specific aftercare. The third one, circumstances or problems influencing a person's health, but they are not in themselves current illness or injury. And 4, newborns to indicate their birth status. You would assign these as a first listed diagnosis when it is for admissions of an evaluation following an accident that would ordinarily result in a health problem. Do not use these as a secondary diagnosis.
So if you have a V code and another code, the V code always goes first?
Nope, it can go first based on the reason for the admission.
Okay, so based on what it's for? Or no?
Right.
Oh.
Based on what it's for, yes. All right, so we already went back to the tabular and looked at in the tabular. They're very similar to your other codes. You're going to see that there are 2 digits before the decimal. So it will start with the V and then 2 characters and then the decimal. You will have an index for the V codes and the alphabetic index for diseases. Now, this is very important. When we were talking earlier about main terms, right? Our main terms under V code will be contraception, counseling, dialysis, status, examination. So what I did at the top of my book is I put tabs along the top of the book for the largest sections so that I could go to that real quickly. All right, some use of V codes. We might, someone coming in for a vaccination, that would be a V code. Okay, they're not sick, but they're coming in to get some health care, they're getting a vaccination. That would be use for a V code. All right, services for resolving disease and injury, such as chemotherapy. Chemotherapy would be a V code. Or radiation therapy. When we talk about aftercare is a term for V codes. We're talking about surgery or fracture. And then again, the birth status, the outcome of delivery. Was it a live born or was it a C-section? Another circumstance or problem that might influence a patient's health but is not a current illness and injury might be an organ transplant status. They come in to see if they're able to donate. Birth status and outcome of a newborn. If we look at 18E, all right. Would be all the way over on page 40. So you see the list of V codes in the guidelines, you have quite a bit.
Yeah.
But for E, these guidelines, these identify the V codes that can be listed first. So when you were asking me earlier about when can they be listed first, these V codes are the ones that you would only use as primary diagnoses. They can be first and additional, or additional only. It's going to be when we look in the alphabetic index and it refers us to a tabular, we're going to pay attention in that tabular if it says to us use additional or additional only. We're going to pay attention to our notes in the tabular, how these will be utilized. Does that make sense?
Yeah.
Okay. So then we also have categories in our tabular for history of V codes. And you will notice that with our history codes, they are divided by personal histories and family history. Let me just find that section in your guidelines. On page 35, number 4, history of. So we have, over on the right-hand column, we have V10 through V15. Those are your personal history codes. Then we have V16 through V19, and those are your family history codes. So what you would want to highlight here would be the fact that it's personal versus family, so that they jump out at you real quickly. All right, now let's turn back to page 46. And on page 46, letter G, we're going to talk about your guidelines for 3, 4, or 5 digits. We've talked about this a little bit before. Your codes with 3 digits are included as the heading for a category of codes. You don't ever want to code a 3-digit code if it requires a 4th or a 5th digit. Remember, we've talked earlier in our classes about highest level of specificity or highest level of detail. This is what I'm talking about. If there's a code with a greater specificity, then you want to make sure you choose it. Because ultimately, if you choose the wrong code, you could get denied, and we don't want that. So if there's a 3-digit code used, you would only use it if there is not an appropriate 4th or 5th digit code. All right, guideline H over on the right-hand side over on page 47 on the left. Guideline H is for the diagnosis, condition, problem, or other reason for encounter and visit. You want to make sure with this guideline that you're listing first the reason for the encounter and then any coexisting conditions. So list first the reason for the encounter or condition or problem. So if a patient comes into the clinic and the chief complaint is severe cough for greater than a week, we have associated signs and symptoms that are extreme fatigue, sore throat, then we don't have a definitive diagnosis. It's not definitive yet. So which symptom do you think you would code first? What was the main reason that the patient came into the clinic? What do you think, Anita?
A. We'll go for A.
For what?
Oh,
For his cough.
cough.
For cough, yes. And then what are the coexisting conditions? The fatigue
Chest pain,
and sore throat.
headache.
The fatigue and the sore throat. So we want to code first the reason why they came in and then any coexisting conditions. Now, guideline I, on uncertain diagnosis on page 47. in your CPT book, ICD-9 book. Sorry. Do not code the diagnoses documented as probable, suspected, questionable, rule out, or working diagnoses. So you want to make a note that this differs from the coding practices that are used by the hospital medical record departments for coding the diagnosis of acute care in short-term hospital patients. With guideline I, you want to code the condition that is suspected to your highest degree of certainty for that specific encounter. J, chronic diseases. These are treated on an ongoing basis. They may be coded and reported as many times as the patient receives treatment and care for that condition. So asthma, diabetes, COPD. Guideline K. One moment. All right. Guideline K, if you're following me in your textbook, what do you have for page, Kelsey?
263.
All right, so 263 in your textbook, Guideline K. So if I didn't point this out earlier, what I would say to you is if you have guidelines in your textbook, I want you to have your ICD-9 book open right beside you, and I want you to be looking at that guideline in your textbook. Find it in your ICD-9 book, because if you're going to make notes about your guidelines, I would rather have you make them in your ICD-9 book. But as I did earlier, as we're doing this now, I will take pictures of mine all marked up, and I will add them to Evolve underneath the chapter so that you can see them, and I download them, I guess. I'll see how I can get them up there, but I don't know why I didn't think of it earlier. Crazy me, right? But that will help, I hope, a little bit. Okay, so Guideline K, you want to make sure that you're coding all of the documented conditions that coexist at the time of that visit that might require or affect the patient care, the treatment, or the management. Do not code conditions that were previously treated that no longer exist. All right? Also, with Guideline K, pay attention to your history codes, because with Guideline K, your history codes can be used as secondary codes, which would impact the current care or treatment. Let's just give you a little note about histories. In the alphabetic index, you would look it up under history. Okay? You would look it up under history in the alphabetic index. For your guidelines L and M, these are patients receiving diagnostic services only. You want to sequence first the diagnosis, the condition, and the problem, or any other reason that is shown in the medical record to be chiefly responsible for that encounter. You can code for other diagnoses such as chronic conditions. The exception with these two guidelines are your therapeutic codes, your therapeutic services. Your patients who are receiving chemotherapy, radiation, or rehab, these would be listed second. So the V code that's first would be the diagnosis, and the problem for which the service is performed is the second. So how do I want to explain that one? I'm drawing a blank right now. Sorry. Okay, now I got it. So if the patient comes in for chemotherapy, we're going to, in this instance, under guideline M, we would do the V code for chemotherapy first, V58.11, and then we would use the diagnosis for the problem. So if they're coming in because they have cancer of pancreatic cancer and they're receiving chemotherapy, we would code the chemotherapy first and then the pancreatic cancer second. Does that make sense?
Yeah.
But that's for this guideline. There's going to be a lot of guidelines, and don't expect to remember them. Remember, it is not about memorization. It's about knowing where to find everything. Okay? All right, so guideline N, this is for patients who are receiving preoperative evaluations only. So you would code from the category V72.8. Then you would assign the secondary code, which is the reason for the surgery, and then any additional findings that are related to that preoperative evaluation. Guideline O, ambulatory surgery, code the diagnosis, which is required, then the pre and post-op diagnosis. If you have a pre-op and a post-op diagnosis and they're different, what you are actually going to code when you read the report will be the post-op diagnosis, because that is the most definitive. Okay? Guideline P, routine outpatient prenatal visits. You want to code the routine visits with no complications. So V22.0 is supervision of a normal first pregnancy, and V22.1 is supervision of other normal pregnancy. This should be used as the principal diagnosis. Do not use these codes in conjunction with Chapter 11, which is your pregnancy complication codes. And what I'd like to do is take a minute and turn you to page 1051. So first of all, make a note on page 47 next to guideline P, page 1015. 1015. And then put your hand or something there and then turn to 1015. And what you will see on the left-hand column is V22, normal pregnancy. V23, supervision of high-risk pregnancy. All right. And then one that we want to add, let's see, 1015. Let me just take a look, one moment. If you turn to page 1035, 1035, this is a new diagnosis category for multiple gestation placenta status. So obviously we have twins, triplets, quadruplets. Okay. All right. That's it for chapter 9. Any questions?
No.
Anita, is your head swimming yet?
Yeah. Yeah. No, I understood.
I know you did. All right. Let's take 5 minutes and we'll come right back and finish up chapter 10.
Okay.
Once you start working, it will be easy.
I guess so.
It's just like an index.
Yeah. Do you have kids?
Yeah, I have.
You do?
Yeah, I have 2 kids.
Oh, you do?
I have 13 and 8.
Oh, wow.
Yeah. I don't. He's in 8th grade.
Wow. It's scary. I have a 15-month-old.
Yeah, he goes to Holland and
Is that a good school system?
okay, good. Means compared to others, it's okay, I guess.
Yeah.
But rating is like elementary school is good.
Mm-hmm.
They have B rating, but high school is C.
Yeah.
But
That's usually how it is, though. Is the elementary schools are better and then high schools
Yeah.
stink.
I got married very early, like 21, 22.
Oh, wow. Got it out of the way.
Yeah. It's also one way it's good, when we are young, if we have, they'll grow faster.
Yeah.
Then you'll have freedom. Now I'm okay. All these days, they're grown and they're doing themselves.
Mm-hmm.
It's easy.
Yeah, right now it's hard.
It's so hard.
And it's
they're
just
small,
me, too. Yeah.
Very small, very hard. Now I'm happy that they do everything by themselves.
Yeah.
I don't have to do. And especially if they have two two brothers, like brothers or sister,
Mm-hmm.
they'll grow together
Yeah.
once. He's 15 months, you said?
Mm-hmm. Yeah, and he's already into his terrible twos.
Yeah. Oh, 2. Oh, yeah, I know. 2 is... the younger one is so active. And when he was 2, he don't like to watch TV. And he used to ask me what to do. What to do next? I said, oh my God, what is this? He wants to do something, but he don't want to watch TV. Then he started going to YMCA, and then he was so happy.
That's good.
No, they are into a lot of activities. That's why I always run around with their activities and all.
Mm-hmm.
So the younger one does like baseball, and the older one does swimming. I had to go to YMCA, and drop the older one, and then come back to the elementary school or middle school, then again go back there. And again. So my older son is not here. They went to Kiev. They have them Kiev, right? They go out for 1 week. They call it as Kiev.
Oh, for like the 8th grade trip?
Yeah, 8th grade trip.
Okay. Yeah.
So he went there for 1 week. He was so excited. And that's one of the reason my house is little calm.
Yeah, I bet.
They're both are there. Oh my God. Last week I could not concentrate. I left my the youngest son in the field, track and field, and then I came here. I texted one of my friend. Oh, I dropped him at middle school, and she said, yeah, okay, that's okay, that's fine. I'll go and pick him up again. So, but still, when I was sitting still, I had that in my mind, Oh my God, I left him, what will happen?
Yeah.
And my older son has cell phone. I was texting him, and he's not texting me back. No, I told him, if you're not texting me back, you're not going to have phone. He always used the phone for like texting their friends or using some game.
Yeah, they always have it, so they're not texting you back.
Oh my God.
It's intentional.
So you're working and then you're also working?
Yeah. Yep, just part-time. But it's still a lot.
Usually, I think I see a lot of jobs in Brunswick area. A lot of them, I think some pharmacy related claims.
Yeah. I know, I'm in Brunswick almost every day. That's where my son's daycare is.
Oh.
But then it's such a long drive going back to Litchfield every day.
Yeah, Litchfield is from here to... It takes half an hour from here, Litchfield.
Yeah, about that, 25 minutes or so. There's a lot of gas, too. So I'll be glad once I get this job and can actually move there.
Yeah, a lot of do you have Well Point down there or Portland? Well Point is in Portland.
I don't know what that is.
Oh yeah, Well Point is like it's like insurance company.
Oh, okay.
You should see like candidatepoint.com. I'll send you. You'll find a lot of claims there, and you meet because Kelly services.
Yeah.
Kelly, they do have a lot of claim related jobs.
Oh, okay.
Yeah.
Candidate Point.
Candidatepoint.com, and then Kelly services also will send. If you register their website, they keep on sending you. They'll have a lot of these
Openings?
Openings and physician offices.
Thank you.
I thought, okay, once this is all done, we can take everything once. Once this is done, and if you have certificate,
yeah,
you easily find a job.
Yeah, hopefully, fingers crossed.
And if you have experience in this, you can start your own too. Like I have seen once I attended a seminar in Augusta. They were showing all this stuff. Like once you have experience, you can start your here they were saying like billing provider.
Yeah.
something like clearing house, billing provider. So billing provider is the one they were talking about.
Oh, okay.
Like you can, if you really have experience in the doctors trust you, they will give their work. You can work from home.
Yeah, that part I did hear.
All right, ladies. Can you hear me okay?
Yeah.
Yep.
Excellent. All right. Before I forget, let me just make a picture. I'll do it afterwards. I'll write myself a note. Take pictures of pages. Take pictures. You know what I'll do? I'll send them to you two ladies first, and you can open them up and see if you can see clearly what to underline and highlight, and let me know.
Okay.
How's that sound?
Good.
Okay. All right. So chapter 10. Chapter 10. Chapter 10.
That's outpatient.
This is where we start using the ICD-9 book. Woohoo! Yay! Are you excited?
Yes.
So
All
this
right.
is that's just week course. This one is like outpatient. Is also outpatient?
Say that again.
No, this is outpatient too. It's
Yes, it's all
outpatient.
outpatient. It's all outpatient. All right. So now we want to go to page 2. All right. I'm on page 268 in my textbook. What page are you on?
70. 270.
270? Okay. All right. So let's see. I want to make sure I get the right page in the ICD-9 book. So we should be on page 3 in your guidelines. The left-hand column, it will say ICD-9 CM official guidelines for coding and reporting. Section 1, conventions, general coding guidelines, and chapter-specific guidelines. Page 3 in your ICD-9 book. Got it?
Yep.
Okay. So, you will see here, over on the right-hand column, under letter C, chapter-specific coding guidelines, it shows you all 17 chapters if you turn the page. So you have your general guidelines, you have all of your chapters, and then you have your basic coding guidelines. So section 1 will present us with the conventions and our general coding guidelines. Section 2 and 3 will outline the selection of diagnoses for inpatient records. And then we have section 4, which is what we just went over in chapter 9. Section 4 goes over the outpatient services. All right. So when we are using the ICD-9 guidelines, it is with the help of these cooperating parties that developed and approved these guidelines that we're able to use them. And I mentioned them to you all before. If you look over on page 2 in your guidelines, over in that right-hand column in the second paragraph, we're talking about AHIMA, American Health Association, the Centers of Medicare and Medicaid, and then the National Center for Health Statistics. So it is because of these cooperating parties that these guidelines have been developed and approved. Now, how many of you have actually gone and looked at your appendix? Not the appendix in your body, but the appendix in the back of the book.
I haven't really spent much time looking at it, but
That's fine.
really gone over it.
Okay. So Appendix A contains a link to access all of your official guidelines for coding and reporting. And actually, if you look at page 271 in your textbook, it's right there on page 271. You see it on page 271 in the second paragraph?
In your book or our book?
271 in your book, textbook. It's underneath organization of the guidelines, second paragraph, first sentence.
The official guidelines for coding and reporting?
Yes.
Okay.
You can find them on Evolve, or you can find them posted at the www.cdc.gov. You see that?
Yep.
Okay. Highlight and underline that. Okay. So then, remember that your inpatient coders are going to use all sections, 1, 2, 1, 1 and 2 and 3 of your guidelines. Your outpatient coders are going to primarily use sections 1 and 4. Okay, so right now we're in section 1. We were in section 4 in chapter 9. So you want to make a note here, used for outpatient services or used for outpatient coding. All right, so you will see here that you have basic coding guidelines and they might not cover all situations. As an outpatient coder, you might also use inpatient guidelines. So, steps to accurate coding. You have this listed in your textbook, steps to accurate coding. Identify the main term in the diagnosis. All right, we've done that in our homework, right?
Mm-hmm.
Okay, and then we locate the main term in the index. So we did that last week when we located Legionnaire's disease. Then you want to review any subterms. Then you follow your cross-reference instructions, your C also, and then you verify the code or the codes in your tabular. Remember, read your tabular notes. always code to the highest level of specificity and never, I mean never, never, ever, ever, never code from the index unless it is a very rare occasion that you will code from the index, and I mean very rare. And the only reason why you might code from the index is because to save space in the tabular, what they've done is they've just left it in the index for you to be able to use it from the index. And honestly, it truly is a very rare occasion that you will code just from the index. I might let you do it in class, but do not get in the habit of doing it, okay? So, guideline section, level of detail in coding, 1B3. So if we look at 1B3, that should put us on page 1B. Okay, page 6. Page 6 in your guidelines. Level of detail in coding. Is everyone there?
Yeah.
Okay. So you want to always assign the diagnosis to the highest level of specificity. We talked about this earlier in chapter 9. Do not use a 3-digit code if there is a 4th digit, and do not use a 4-digit code if there is a 5th. Because why, Kelsey?
Because it's the wrong code.
And if we do that, our claims might bounce, right?
Yes.
All right, excellent. All right, number 7, over on the right hand on page 7, conditions integral to disease. All right, this is where we have signs and symptoms that are routinely associated with the disease process, but they should not be reported separately unless we are instructed otherwise in the classification. So if I give you the example, fever and shortness of breath due to pneumonia, what am I going to report, Anitha?
Shortness of breath.
No? What do you think, Kelsey?
Oh, we like
Go ahead, Anitha, what were you going to say?
maybe cough.
No. These are, okay, let me repeat this. Signs and symptoms that are associated routinely with a disease process that should not be reported separately. So my example to you
So it's
is
pneumonia. Sorry.
Yes. Fever and shortness of breath due to pneumonia. In this instance, the fever and shortness of breath are symptoms or signs that may be associated with pneumonia. So unless we are instructed in our tabular to code it, the only thing we would report here would be the pneumonia. Does that make sense?
Yeah.
Okay. All right. Number 8, conditions that are not an integral part of a disease process. So if we have additional signs and symptoms that are not routinely associated with the disease process, they should be reported. So if I give you the example of dehydration due to pneumonia, Anitha, what am I going to report first?
Dehydration.
Think about it again. Dehydration due to pneumonia. So the additional signs and symptoms that may not routinely be associated with that disease process should be coded when present. So why is the patient coming in? What do they have?
They have pneumonia,
They have
Yes.
but their dehydration is due to the pneumonia, so you still want pneumonia
Yes.
first.
Okay.
So your pneumonia is first, and then your dehydration. Does that make sense? Okay. All right. So then number 9, multiple coding for a single condition. This is where we have 2 codes that fully describe a single condition that might affect multiple bodies, multiple body systems. All right. So this is where the etiology and the manifestation convention requires that there are 2 codes to fully describe that single condition. Some of the instances or single conditions may require more than 1 code to fully describe the condition. So over on the right-hand column, you'll see to use additional code notes. You'll see them in your tabular codes. When we have use additional code indicated, that means that your secondary code should be added. When we see code first in our tabular, it means that it may be found under certain codes that refer to conditions that may be due to an underlying condition. So that underlying condition would be sequenced first. And if we see code, if applicable, any causal condition, this note indicates that this code may be assigned as a first listed diagnosis when that causal condition is unknown or not applicable. So what's the etiology, Kelsey?
Etiology is the first condition.
Right. What I'm looking for is that etiology is the cause.
Oh, okay.
Etiology is the cause. And what is manifestation, Anitha?
A body part like lung.
Your manifestation is going to be the symptom. So when we see a cause and a manifestation, so a cause and a symptom, an etiology and a manifestation, you might find the symptom will be listed in slanted brackets. So the example I'm going to give you is diabetic retinopathy. This is where we use 2 codes for a single condition. Now, the patient is coming in for what?
The retinopathy.
The retinopathy. And
So the diabetes you would code first because it's the cause.
Yep.
Retinopathy is the manifestation.
Yes. Exactly. You got it. Perfect. Okay. Let's try this. Try another one. Now, when we code that diabetes, though, just a note to add on to that, make sure you code the 5th character, because when you look up the 250.5 code for the diabetes, it's going to ask you for a 5th digit subclassification. So you want to make sure that you are always coding to that highest level of specificity, okay?
So you'll have 2 codes for diabetes or one?
One.
Just
okay.
Just
one. It'll be the first one. But if we were to go to our tabular right now and look up 250.5, it would ask us what subclassification. Is it controlled? Is it uncontrolled? Is it insulin? Okay. Actually, let's just take a moment and do that. Put a placeholder here so we don't lose our page. And let's go into our tabular to 250. So if we look at 250.5, 250.5 is on page 732 in your tabular and your ICD-9 book. And up at the top left-hand side, 250.5, diabetes with ophthalmic manifestations. And then underneath it in brackets, you have 0-3. What those brackets are telling you is that you need to code a 5th digit. So the red dot, I call that my stop sign, basically is telling you you need to code more. You need to code more. So you have a 4-digit code. The brackets underneath with 0 through 3 means that you need to code a 5th digit. Right underneath this, diabetes with ophthalmic manifestations, it says, use additional code to identify manifestation as, and then it says, diabetic blindness, cataract, glaucoma, macular edema, retinal edema, and retinopathy. Now, before you do that,
you go to retinopathy and find out which one?
Before you do that, turn the page back to 731. You see in the right-hand column, it has a gray box.
Yep.
All right, look above that and you'll see category 250, diabetes mellitus.
Okay.
Remember, the 3-digit is your category code. So when I say to you, read before, middle, and end, this is what I'm talking about. When you come to a code, always go back to the category to see where it starts. And this is diabetes mellitus. And you read on and it tells you it's a metabolic disease. It tells you what it excludes. And then underneath it says the following 5th digit subclassification is for use with category 250. And it gives us this gray box and it says 0 through 3. So 0 is type 2 or unspecified, and it goes on to tell you use additional code. Number 1, type 1, juvenile type not stated as uncontrolled. 2, type 2 or unspecified type, uncontrolled. 5th digit 2 is for use for type 2 patients, even if the patient requires insulin. And then it says use additional code if applicable for associated long-term current insulin use, V58.67. And then 3, type 1, juvenile type, uncontrolled. So when you see brackets underneath a code, you want to always go back and find that subclassification box, because then your 5th digit will be one of these codes. It will be 0, 1, 2, or 3. Now, I honestly don't know what 5th digit I would use because I just gave you diabetic retinopathy. But if it was for a type 1 juvenile type uncontrolled, I would use 250.53. So if I go to 250.53, I again would look and see, use additional code to identify manifestation. So is the patient, do they have retinal edema? Well, I said it was retinopathy. So in the parentheses, it says look at 362.01 through 362.07. So again, I use something to hold my place here in these two pages, and I go to 362.01. So if we go to 362.01 on page 781, page 781 on the right-hand column, okay, top of the column, the category is 362, and it says other retinal disorders. So then it tells us what it excludes. And if we look at 362.0, it's diabetic retinopathy. What does it tell us underneath?
Code
It says,
first diabetes.
yes, code first diabetes. So we know right there we're going to code first our diabetes. And then as we read down, okay, read the red. Then we look at 362.01, background diabetic retinopathy, diabetic retinal microaneurysms, diabetic retinopathy not otherwise specified. Now, obviously, we would go down through and read each one of these codes to see which one is the most appropriate for what I just gave you for an example. So diabetic retinopathy. In this instance, 362.01 is the most accurate code. So we would code the diabetes first and then code the retinopathy. Does that make sense for both of you?
Yeah.
How about you, Anita?
Yeah, I'm a little confused with this.
Okay, well, tell me what's confusing.
Like here, we are here, right? Like on the page 732.
Okay, page 732.
So, okay, we are here in the diabetes. This, like, I don't know. Can you explain again? I'll just try to concentrate.
Yep. All right, so my example to you was diabetic retinopathy.
Yeah.
So we go to diabetes with ophthalmic manifestation, and it tells us to use an additional code to identify the manifestation.
Yeah.
Because I said to you, retinopathy,
Yeah.
retinopathy,
So here, and then we go to retinopathy. Here.
right,
Oh, this one. Here.
on page 781.
Yeah. 781, yeah. Yeah.
Okay, and because the diabetic retinopathy is not otherwise specified, I'm going to use 362.01.
Yeah. No, I think I'm getting confused with the 1 and 2. Why? Oh, it's okay. This is more specific. 1 is more specific. Yeah, because
Yeah.
here proliferative is there. Yeah.
Right, right.
So if it said like type 2 or unspecified type, then you would put the 0 instead of the 1, so 362.00, right?
If it said severe or moderate or mild or non-proliferative, then I would use those codes. If you're talking about the diabetes code, If it was unspecified type or type 1 uncontrolled or type 2 uncontrolled, then my diabetes code would be 250.50, 51, 52, or 53. But then my diabetic retinopathy would still be 362.01
Yeah.
because it's
Got it.
diabetic retinopathy.
Retinopathy, yeah.
Does that help?
Yes.
Yeah.
A little better?
Yeah.
All right. So then let's turn back to page 7 in our guidelines. And let's talk about acute and chronic conditions. So what's the difference between acute and chronic? Kelsey, what's acute?
Not as bad as chronic.
Acute is means the disease is staying for some time. Like
Recurring.
chronic is for ever. Like you
Right.
just have.
Acute is short and severe, and chronic is persisting over a long time. So we have, let's say if there's the same condition that is described as acute and chronic, you might see separate sub-entries with the same indentation level that exists in your alphabetic index. If you have an acute and chronic, they would be coded together, but you would always sequence the acute first. So if you look in your guidelines, it tells you right there, acute and chronic and separate subentries exist in the alphabetic index at the same indentation level. Code both and sequence the subacute or acute code first. Keep that always in mind. If you have acute and chronic, acute will always be coded first. You may actually have some combination codes that describe acute and chronic. So I'll give you a few examples. If we have acute and chronic pancreatitis. So I want you to go into your alphabetic index and look up pancreatitis. And yell out what page you find it on.
414.
All right, it's in the middle column down near the bottom, and it says acute, annular, apoplectic, and it goes on to a whole bunch of others. So we said acute and chronic. So we're going to go into the tabular under 577. And what page is that on?
Eight
854. So if we look in the left-hand column under 577, we see the category is diseases of pancreas. 577.0 is acute pancreatitis. 577.1 is chronic pancreatitis. Now this is where we pay attention to our excludes, our includes, any references that we have. If we have two separate codes, we want to code what first?
Acute.
Yes, the acute first. So what's the code for the acute?
577.0.
0.
Yes. And the chronic?
577.1.
1.
Perfect. So again, always code the acute first. All right, let's look up our combination codes for both acute and chronic. Let's look up diarrhea. We have acute and chronic diarrhea. So again, yell out what page you find it on.
It's 196.
All right, 196. All right, we have diarrhea. Now, all of those parentheses after diarrhea, what are those?
They're non-essential.
Right, they're
Only have to
non-essential modifiers. Exactly. So we have acute and chronic. Where should we start looking?
Like 006. Acute for 006.
So 787.91.
Yes, 787.91. So let's go to 787.91.
What here it is? Acute here, right? Oh, okay. No, this one acute here.
Yeah, but that one's because then you're looking under amoebic.
Oh, okay.
Page 945.
Page 945, we have 787.9 as our category. It says that it excludes, and it tells us what it excludes. Then we have 787.91 diarrhea, not otherwise specified, and 787.99 other, change in bowel habits. All right, so what do you think we should code for acute and chronic diarrhea?
787.91.
Exactly. Tell me why.
Because it's not otherwise specified here, and acute and chronic are non-essential.
Correct. So this is where those modifiers come in, because it tells us that to choose 787.91 is correct because those modifiers were there. If those modifiers weren't there, we probably would have been lost. Would you agree?
Yeah.
Okay. All right, let's look up another one. Let's look up acute and subacute bacterial endocarditis. What are we going to start with?
Page 232, endocarditis.
Endocarditis, right. All
And
right.
it says acute or subacute, 421.9.
Okay, very good. So subacute, acute or subacute, 421.9. All right, 421.9 is on page 806, right-hand column. So 421, the category is acute and subacute endocarditis. So from there, we look at 421.0, 421.1, and 421.9. And my exercise to you was simply acute and subacute bacterial endocarditis. Which one would you choose, Kelsey?
421.0. Oh, wait. Yeah.
All right, and Anissa, once you get a chance to look at it, you tell me which one you would choose.
Acute and
It's acute and subacute bacterial endocarditis.
so first acute comes or subacute? If
Acute
both
comes
same.
first.
And yeah.
Okay, so in this instance, what we have here is called a combination code because we have our acute and our subacute together. So in this instance, 421.0 would be the correct code for this information that I asked you to code.
So that would come after 424.90 for endocarditis.
Well, we wouldn't need to use 424.9. We only need the one combination code, the 421.0, because it specifically, if you look in underneath the acute and subacute bacterial endocarditis, it tells you endocarditis and then our modifiers, acute, chronic, and subacute. And then it goes on to list the type. So bacterial, infective, all right? And then it will tell us down below to use additional code if desired to identify the infectious organism. That's the only other code we would use here. We would not use the 424.9 because if you look at 424.9, we're talking about a valve being indicated, and my exercise to you was simple acute and subacute bacterial endocarditis. I was giving this to you to give you the example of a combination code. Okay.
I got stuck here. We see here acute endocarditis, right? Unspecified. It's 421.9.
Yep.
And then again we had to see 391.
42091? Nope. 42091 is acute idiopathic pericarditis.
Not 421.9.
Okay.
Acute endocarditis and
Right. But what are you missing here? If you look at the difference between 421.0 and 421.9, you don't have bacterial in 421.9.
Mm-hmm.
But in 421.0,
yeah.
I specifically said acute and subacute bacterial endocarditis.
Mm-hmm.
So what's going to actually confuse you if you don't pay attention to your exercises is the exact terminology. You want to get the code that is most accurate to the codes you're looking up. So if I had said acute and subacute endocarditis, then yes, 421.9 would be correct. But I was specific in saying bacterial. Okay?
Mm-hmm. Yeah, I got it.
Sure?
Yes.
Okay. All right. So you always want to, if there is a combination code, use it if it exists. Because when you do that, it will fully identify that condition. So if there's a single code, use that. If there's a combination code, use that. All right, late effects. So let's turn back to our guidelines on page 8. So our late effect codes, they are not in a separate chapter. Instead, they are going to be listed in your alphabetic index under late effect. So if you turn to the L's in your alphabetic index, you will see that it says late on page 325. Okay? Pretty good size section for late effect. So a late effect is a residual of a previous illness or injury. So it's something that is remaining from a previous illness or injury. Yes, a sequela. So a scar that is produced by a previous burn, or a scar from a cut or scrape. Those are late effects, residuals. There is no time limit for a late effect. It could happen, within hours, within weeks, within months, within years. There is no time limit. And generally, when you have a late effect, it requires 2 codes. You have the code for the current injury or illness, and then late effect. So if we have a patient who has a stroke and he has residual paralysis on the dominant side, how would we code that? What do you think, Kelsey?
Can you repeat that?
Patient has a stroke or had a stroke, and he has residual paralysis on the dominant side. So paralysis and aphasia. So paralysis would be hemiparesis, and then we have aphasia because the paralysis is going to affect the brain, right?
Mm-hmm.
So the residual here for a patient who has had a stroke is going to be that hemiparesis and the aphasia. So if a patient comes in with a stroke, how did that stroke affect that person? In this case, in this example, the patient is still paralyzed on the dominant side, and because of that paralysis, they have some aphasia into the brain. So when we're coding late effects, we want to know what the effect was on the patient. This is going to be important, especially when we're coding our cerebrovascular diseases. Give me one moment. All right, let's.
So you should see lateral something.
What?
Like lateral. Yeah. Like paralysis, lateral paralysis.
What page are you on?
It's 326. Here saying lateral, LATRAL.
Oh, latent or lateral?
Yeah.
Okay, not lateral and not latent. A late effect for paralysis. If we know how the stroke affected the person, look under late on page 325 over on the left-hand column. If we know that it was a stroke, then it would be a cerebrovascular disease. And if you look under cerebral vascular disease, it will say conditions classifiable to, and it gives you some codes to look up in the tabular. And then it just goes on to tell you what are the things that happen during that cerebrovascular event. So what late effects do we have? Do we have alterations of sensation, aphasia, apraxia, ataxia, cognitive deficits, dysphagia, facial droop, facial weakness, hemiplegia, hemiparesis. Okay, so be very cautious when you're coding for cerebrovascular events for late effects. Bless you, bless you.
Thank you.
Okay. All right. So, any questions in this chapter?
No.
All right. Did I give your brain a workout?
Yep.
All right. So homework for next week. Homework, homework, homework. And I will take those pictures and try to get them up on Evolve tonight. And by the weekend, have the rest of the exams ready for you guys to take. So homework, Evolve chapters, read chapter 11 and do the review. Hold on. Just read chapter 11. And do the in-chapter exercises. All right, and then your exams for chapter 9 and 10. And again, if you want the copy of the answers, just send me an email and I'll send them to you if you want them. Next week is the 20th, right?
Yes. So are we doing
Alright.
theory and practical for 9 and 10?
Yes. So next week we'll go over the answers for 9 and 10 in both the textbook and the workbook. All right. What is your takeaway from tonight, Anita?
Yeah. I'll just go again and repeat. Then I did understand.
I know you do. I know you did.
I am little slow compared to her.
That's all right. There's nothing wrong with that. And Kelsey, your takeaway?
Remember to look at every single note in the book before I write down the code.
Very good. That is probably the number one most important thing. Okay. Have a great week, ladies.
You too.
Sorry
Thank
for all
you.
the technical difficulties earlier.
That's okay. Still out
All
on
right.
time.
All right. Enjoy your week.
You too.
Thank you.
Take care.
Thank you. Oh my God, it's so specific. You have to just go going in the paper.
Right? By the time the end of the class
just
comes,
for
it's
one.
like,
That means if you especially if you work in a hospital, I guess you can do maybe 10, 20 courses a day.
no.
Not more than that, right? I guess if you are experienced, maybe fast enough. I don't know. And it's the here the print is so small, and I can't see. Sometimes you just blur.